This week on the BackTable podcast.
In my personal opinion, we just don't have the manpower for vascular surgeons to take care of all these patients. And then to try to divide us like that, I just think was wrong. And I think we can do a better job. And, if you take a look at where the majority of the vascular surgeons are, they're all in large cities. I've worked in the middle of the country, albeit in a big city, Dallas, Texas, but I got a lot of referrals from areas that were 2, 3, 4 hours away that had no vascular surgeons, and everything was being cared for by general surgeons, radiologists, and cardiologists, for which there are a lot more than there are vascular surgeons. And until we can get a larger group of vascular surgeons to say, I want to go out and work in a town of 20,000 with the nearest referring city 3 hours away, I think we have to be more inclusive for the management of peripheral arterial disease and CLTI and really work as a group. There's just too many of these patients to manage, and the OBL and the ASC can take care of these patients in a much more efficient way than a hospital, and the government is pushing it towards that. All we need is probably some regulations, some changes in the payment, and these systems actually, I think, can work very, very well for these patients in the long term.
Hello, everybody, and welcome to the BackTable podcast, your source for all things interventional and endovascular. I'm your host, Dr. Ali Baheti, coming to you from Tacoma, Washington. Our guests today are Dr. Saher Sabri, Chief of Interventional Radiology at MedStar Health in Washington, D.C., and Dr. Frank Arko, Chief of Vascular and Endovascular Surgery at Atrium Health in Charlotte, North Carolina. Welcome to the show.
Thank you. Thanks for having us.
Yeah, thank you.
Our topic today is the recent New York Times article about PAD treatment that was published a few weeks ago. It was entitled, "They Lost Their Legs, Doctor and Health Giants Profited." For those who maybe haven't read it or haven't heard about it, it was an above-the-fold article about peripheral arterial disease treatment in an outpatient-based lab by an interventional cardiologist. And that's kind of really ignited a lot of controversy within our specialties. And so we wanted to bring these guys on today to talk about it. So I'll just start with Saher first. How did you first become aware of this article?
Twitter. So
Yeah.
as soon as it was published, we knew about it, and my phone started blowing up. Everyone started texting me, "Did you see this?" So,
oh man, yeah.
It's pretty quickly in this day and age. People know about these things quickly. So, so we knew about it as soon as it happened, and I just read it, and we'll talk about how I felt about it, but just immediately, as soon as it happened, we all knew about it.
How about you two, Frank? Twitter's where you first found out?
Interestingly enough, I had someone text me the article pre-publication. Vascular surgeon. I won't give the name away.
Very interesting. Okay, so you kind of saw it before everybody else. So what was your initial personal reaction to it?
I think my first sort of thought was, I think there's probably some amount of activity that is nefarious in some of the OBLs. I thought this article was a bit sensationalized, to be honest with you. I think that the majority of OBLs from all specialties, and as a disclaimer, I don't have an OBL. I have a very good working relationship with vascular surgeons that do have OBLs. But, and I sort of knew a lot of the people that were within the article, those that were sort of maybe a little bit disparaged in the article. So the primary operator of that OBL, who I know just a little bit, I wouldn't say I'm an acquaintance or a friend. I'm not going to make any comment as to what the care is given up there, because frankly, I just don't know. I do think that he's technically a very gifted interventionalist. I don't know what his indications are. And I thought that some of the vascular surgeons that were quoted within the article were a bit harsh in their evaluation of what was going on within that OBL. And the reason I say that is because I just think that, it's easy to be a bystander and sit on the side and give an opinion as to what you think. But when you're looking at an article that is going after someone like this, I think that most of it should be based on, a bit more fact, and an understanding of the numerators and the denominators and all these sorts of things. And that was sort of my first opinion of the article, sort of pre-publication.
Yeah, and how about you, Saher? I think I talked to you the day it came out, and you definitely had some strong feelings about it.
Yeah, I mean, I think it was a missed opportunity. I mean, this disease process, PAD, CLTI, is something that the public doesn't know much about it. We all struggle with, what to name it, how to present it to patients and such, and to kind of get onto, a first page or above the fold of New York Times, and to get this much publicity. My hope was it was in a different, setting, and, pointing out the disparities in amputation and, poor limb salvage, in certain parts of the country and certain populations, especially minorities, the issue of poor access to revascularization prior to amputation. I mean, these are the main issues that affect our field, and educating patients of what to do if they hear they have arterial disease in the legs, So I was hoping that, they can use that platform, even if they kind of highlighted some of the, as Frank was saying, the sensational aspect of it or dramatic aspect of it, the hyperbole that was in there. Fine, they have to do this for the, shock and awe effect of the, the media and journalism. Fine, they want to get clicks and they want to get eyeballs on their paper, but there was a lot in there that we could have basically then shifted and highlighted the other aspects that what we can do to do it. And I was hoping everybody who was quoted in the article to focus on that piece, but it ended up being mostly just going after people and, it was mostly personal attacks and with not a ton of facts. I mean, there's some things in there that, number of interventions on one patient, fine. But, as a patient who came with a claudication or asymptomatic, then 14 years later had an amputation, or a patient came in the first sentence in it said it started with a festering wound, right? I mean, it's a CLTI patient, the very first word of the article. So it's a CLTI population that patient ended up losing their, the leg in a year and a half. And then, having a picture of somebody who's losing their leg. And I mean, as we sympathize, of course, we don't know a lot of the stories of what happened and why this many interventions were done. And some of them were bypasses, some of them were endovascular. But regardless, that's not the point. It's just trying to, highlight a story of CLTI in a bad way, but didn't put any kind of perspective on it, what else can be done.
Yeah.
So that was my first impression. It was just a missed opportunity and just going down, just trying to have a, sensational article and more than anything else.
So then you were probably getting blown up, each of you respectively, from your individual bubbles of people texting back and forth about the article or talking on Twitter. So what were some of the initial responses from within your bubble? Saher, I'm specifically thinking about from the other Viva folks or other IRs. What kind of responses did you see?
Yeah, I mean, just to be clear, I'm here representing myself only, so I speak on my behalf, yes. And I don't represent any organization for us. So just to be clear, but definitely, you speak to old people or people that you associate with, and same Frank, the same way, and everybody else who's been in the field. So, I speak to a lot of people who just start texting me and talking about it. I mean, the general sentiment was, let's be cautious about, what it is. Let's let the dust settle. Let's just, being on, should not be resolved on social media. And we just have to kind of see what the reactions are before doing anything major. So that's mostly, the reactions have been. A lot of people were definitely upset about this is going to scare people away from seeking care when they have PAD, especially CLTI.
For sure.
And may scare them away from OBLs, which, for the record, I think it's a great way to provide fast and efficient service, notwithstanding that there's some major issues and some bad actors and, that and we know, and it's not just in the arterial side, also in the venous side and overstenting and things like this. So we know that there are issues. But that's the current platform that we have, and it's there, and there's providing a lot of great service. So the worry was it's going to scare people away. And, so that was probably one of the biggest, message I heard from people.
And then, Frank, I felt like the vascular surgery response to this on Twitter was really split. Could you give me a little bit more insight into what you were hearing?
Yeah, I would agree with that. I don't know how much it was split. I certainly have vascular surgeons on both sides. I would say that a lot of the younger ones who probably have, and I'll be honest with you, I think the younger generation of vascular surgeons are probably a bit more skilled when it comes to a percutaneous intervention for the management of CLTI. And I thought that they were not, supportive of the article, nor the response to the article from the SVS. I think a lot of the older generation of vascular surgeons, and that might include my generation, I think, to be honest with you, I think it's a generation, maybe 10 years above me. I'm in my 50s, I don't mind saying that. And, I think they just have an open bias to the management of vascular disease. And I think there's still maybe a bias towards a lot of vascular surgeons with regards to the open reconstruction of these patients. And I think when it gets down to it, in that article, the very first patient did have critical limb ischemia, right? So she had a wound. We don't know anything else more about that than she had a wound, but I suspect that she probably had diabetes and had very low toe pressures, and most of her disease was probably tibial. That's the way that most of our CLI presents, at least in our own practice. And I would say that the majority of those patients, for numerous reasons, are not great candidates for open repair.
Sure.
And, I just think it's very split within the vascular surgery community, but, I can only speak for myself and those that I know. And I think I have good communications with a large number of vascular surgeons as well as IR and cardiologists. But I think the response that the society gave, and I've never made any voice on Twitter my thoughts were with regards to the response. I ran a vote and a poll, which had a lot of votes. And I sort of listed the things within that I thought were reasonable things to conclude from that article. It was excellent. It sort of missed the spot, or it was basically divided the specialties. And I think one of them, it wasn't strong enough. Personally, I thought in different areas of that response, as a vascular surgeon, I sort of thought it hit all of the four that I mentioned. I thought in some ways it was good. I thought in some ways it sort of was maybe a little bit too soft, not specific to that operator or the article, but what's going on in an OBL or an ASC. And I think we need to be cognizant of that and sort of, look at it from multiple societies to say, what's the best way to regulate this to make sure that the majority of these patients are getting great care? And I do think that the majority of them are getting great care. I think, the operators that are pushing the limits of what needs to be done versus medical therapy is probably relatively low. If you read this article, it made everybody that had an OBL or an ASC look like they were just doing, inappropriate cases. But in the end, I just thought that it was a little bit, created some anger and some angst amongst other specialties. If I was an interventional radiologist or a cardiologist, I would have looked at that response and said, there are other specialties that can manage this disease. And I think that those other specialties do understand when someone can have an open bypass. I think that those specialties can look and determine whether someone has a adequate conduit for a bypass. I would certainly say that in my own hands that I think that the majority of the patients can actually be managed from an endovascular standpoint. Not all. I mean, if you give me somebody's got a great vein and they occlude at the common femoral and they don't reconstitute till they're AT and they've got a 4 millimeter greater saphenous vein, that probably should have a bypass as long as their other comorbid conditions allow them to have that bypass. But
Sure.
I think that sometimes the vascular surgeons will take the last two trials that have been done and then say, we can do this and we can do open surgery. But again, we have to remember that it was a greater saphenous vein that was of good quality. And I would say that the majority of the patients that I treat on, and this gets into your disparities, the minorities, the majority of those individuals do not have, in my practice at least, do not have an adequate greater saphenous vein. And if you take a look at the trials, when you don't have adequate greater saphenous vein, endovascular is probably equivalent in those patients that need revascularization. I'm starting to see, surgeons on that sort of fringe of the 30%. Well, I can get arm vein, some lesser saphenous veins, splice those together and do a bypass. You might be able to do that, and if you're one of those centers that excels at that, that's great. But the majority of the United States of America, and I'm only going to speak for our country because this article sort of, focused in on the USA, I would say that the majority of centers are not capable of doing that. So that's sort of my thoughts on what's going on currently.
Ali, can I add on the vascular surgery response, if you don't mind?
Absolutely, yeah.
So, I think it's, I hear what you said, Frank, and I think about the young vascular surgeons, and I've noticed also that there's a group of young vascular surgeons who are very skilled, who are kind of trying to push the agenda of appropriateness, which, I think there's a lot of it is really great, and there's a lot of great work that was done, especially out of Hopkins, and talking about claudicants and over-treatment of claudicants. And there's some really great work that was done and showing that there's some 30% of patients who had claudication had below-knee interventions, which is, something that's really,
wild,
really disturbing to see. So, there's some bad work is being done. And in that article, they looked and they saw that the majority of these interventions were done by IR and IC and not by vascular surgeons. So that's what the basic Medicare claims. So there is some reality to some of this information. So this stuff was presented, and I think, and there's some other work about overuse of atherectomy. A lot of it is in claudicants. And I think there's increased awareness of this. And I think a lot of the young vascular surgeons who are skilled in both endo and open, to be honest with you, now more skilled in endo than open because a lot have not done enough bypasses, are definitely trying to kind of push this agenda, which I think there's a lot of good in it. But in this scenario that happened, since a lot of discussions were on CLTI and such, it was just like almost misplaced. And it just came in like very strong on social media. And then with the SVS president's response, who I respect a lot, it just missed the mark. And it just came out as divisive as the the whole comprehensive vascular care, we the only specialty who can treat the patients comprehensively, and just like that was not the time to do it. It seems like we're already a lot of the walls being built, a lot of silos being created, especially after Best CLI was published, and there's a lot of bravado was after the study. I think you alluded to all this stuff now in what you just said, and people trying to kind of exaggerate the results of it. It's like, and extend it to arm vein and to extend it to even a graft, over endo and all that stuff. So, and we heard a lot from people. It's like, you have to offer both, otherwise you should not be treating the disease. So unfortunately, we're going back to where we were 10 and 12 years ago when things were bad, because we've been in a good spot till these articles came about. So it's kind of unfortunate, and it's unfortunate some of the younger crowd and vascular surgery are just pushing in that direction as well. And it's not just, so there's kind of like the ones in the middle, that's kind of my impression, that I worked with a lot. They seem to understand the collaboration aspects of it. And then the old guard have always been, had this, vision of the, protecting the specialty. And it seems to be some of the younger crowd are heading in this direction as well. So that was kind of my impression from looking at it. And I hope it doesn't go into this, and I hope there's more kind of discussion across specialties to try to kind of calm things down, because we really, at the end of the day, the patients end up suffering, and if we start having competition between specialties, because everyone's going to have something to offer. There's not enough vascular surgeons to treat every single PAD patient in the country, and same goes for IRs and ICs. So we know that we need all hands on deck. I mean, it's can't all the treatments be concentrated in big urban cities and big centers. We need people to go out in the communities and the small communities and treat them. And then, as you said, I mean, you don't have somebody who can do an arm vein or even a big distal bypass there. I mean, you need more people who can do endovascular, who can be trained, and you got to lean on your other non-surgical specialties to help with that and outreach, including OBLs. So that's just my comment on the response.
Would either of you like to comment on the timing of the SVS statement? One of our collaborators had a question. More of a comment. Seemed like the SVS had an agenda and they had a statement ready very quickly after it came out. Do you care to comment on that?
I'll comment first, and then I'll give it to Frank quickly. I would just say we have to be careful with these things and not to really push, narratives that we don't know about. Again, but
Sure.
I would say that it was a missed opportunity to get people together. There was a lot of, chances to get multi-societies to collaborate and write an article, and it was a missed opportunity to try to in a way, capitalize on a bad situation, to service one specialty. At the end of the day, the board of directors of SVS is going to care for their constituents, which is vascular surgeons. But I would say that it was a missed opportunity, and it just left a sour, taste, for a lot of people. So, and the response to VSCLI was somewhat similar as well. So, a couple of things back to back were not great. But I would just be careful about narratives because we don't know the details. Yeah, sorry, Frank.
Sure.
Yeah, I would say I don't know the details either. I am a member of the SVS. I didn't receive any communications about the response to it, so it was probably a bit more of a board-related response to the New York Times. I think that, when an article comes out and it involves sort of two specialties within the article, I don't recall any mention of an interventional radiologist within the article. The article
There's
sort of
one.
was...
Yeah.
There is one. So, if you've got three people within the article or three specialties within the article, personally, I think the response to the article would have been better managed from a combined response from, whatever specialty it is for each one. So if it's the American College of Cardiology, Society of Interventional Radiology, and the Society of Vascular Surgery, I think that would have been a better response. It could have tempered sort of the, there's a multitude of individuals who can treat these patients, who have to treat these patients based on the epidemic of CLI and PAD and the number of physicians that we have. And furthermore, the recognition of the disease even earlier. I mean, us getting CLI patients with festering wounds is probably a bit too late. We'd like to have those patients prior to the wounds. I think we can do a better job with those patients. So that would be my sort of response to that. I thought the SVS response was a little bit early. Maybe if you're going to do it from a single society, maybe have it reviewed by a few more people within the society so that it represents the society as a whole rather than maybe the 5 to 15 people who wrote the response.
Very, very good statements about that. A question from the audience: in the best situation possible, even with a quality and outcomes reporting system, how do you avoid this type of political nightmare when you're taking care of high-risk patients as the operator?
Yeah, I mean that's a really tough question. I think when it comes to CLI, when you're dealing with wounds, at least the indication is at least there. I think as Saher spoke about a little bit earlier, the vascular surgeons I think get concerned when there is no wound and where is this sort of cutoff from claudication to limiting claudication to sort of early rest pain. And I think there needs to be, potentially some sort of oversight to the management of these patients to prevent that. I mean, again, I don't have an OBL, but I understand the economics of an OBL, and there's clearly got to be a conflict for some physicians. I'm not going to say all, but but for some physicians to do the right thing. The economic benefit from doing that procedure, and I think we just should say what that procedure is. It's atherectomy, right? So, and I'm not against atherectomy. I do some atherectomy. I wouldn't say I do atherectomy in every case. I'd say I do it, maybe 20 to 30% of my practice. I don't know if that's too little. Some people might say it's too much. Some people might say it's not enough. I think it certainly works for my practice. So, and, at some way there's got to be some oversight of that, economic, that significantly positive economic benefit from doing that procedure in the OBL. How to govern that, I'm not exactly sure. You'd like to think that every physician is altruistic. I think that the majority of them are, personally. I think that there clearly are some bad actors, but I also know that there is an epidemic of PAD, and if you clearly just focus in on CLI and that population, from the economic side of it, you could still do very well without having to intervene on any claudicants, in my personal opinion.
Well, and when they were talking about atherectomies in the New York Times article, they linked to this Cochrane review, which let me see if I can get to the page. It says, studies have found that atherectomies do not work better than less expensive methods of clearing blockages and restoring blood flow. But when you click on that link, the Cochrane review doesn't say that. It just says we need more data studying atherectomy. So was it just me, or did you guys feel like the author didn't really understand the difference between claudication and CLI when she wrote this?
Yeah, there's no question. That was my biggest gripe with the article, is that it just really lumped everything together, and it just kept bouncing back and forth and equating the two diseases. When everyone who treats a disease knows how huge of a difference it is. And using atherectomy and CLTI versus claudication, instant restenosis versus de novo lesion above knee, below knee. I mean, there's a lot of nuances to it, and it just lumping all of it together is a major issue here. And again, this article is not written for the medical community. It's writing for the general public, and you owe it to the general public to be very clear about it. I mean, there's one paragraph in there talking about most patients with PAD do not need treatment. Medical therapy is enough.
Sure.
And just brushes over that and just jumps again into, kind of attacks and such, which, and going back to the original question about the complications and how do we deal with it? Because how many of us have not sent a patient for a major amputation? I mean, if you have not, this means you are not treating enough CLTIs. I mean, that's the way it is. 20-30% of patients end up losing their leg in 1-2 years, and it's the way it is. I mean, limb salvage rate and for pedal access at 3 years is 50%. I mean, it just amputation for survival is 50%. So I mean, it's really tough patient population. So it's going to happen, and if somebody's going to come and pick them, in the article it says 42 patients were sent, and this is some claims data from their private insurer. 42 patients had amputation. Well, out of how many patients? What's the denominator? I mean, it is. Yeah. And there was still.
That was over a pretty long period of time, I think, if I remember the article. I want to say it was over about a 4 or 5 year period of time. So it's not like there were 45 in a single year. That would be a little bit high. But over that time frame, not knowing the number of patients he's treating, it's very difficult to understand what that rate is.
I mean, there was self-reported rate of 1.3% and at 1 month. Although David said there's also some like stuck wire or something. It could happen. I mean, so the problem is like if we all do M&Ms, we all do this. I mean, we all have some, and that's the nature of it. I mean, we make mistakes and these are going to happen. The question is this out of the ordinary? Is this something that is outside of the scope of the practice? Because complications going to happen. And if we're going to basically judge our complications in the public arena, it's a slippery slope. It's a big problem. And if it's a way to people to settle scores and taking it to the media, that's not the way to do it. I mean, if it's at the state medical board, it's at the hospital credentialing committees, this is how these are established. And my understanding from the article is that these operators were investigated and not a whole lot came out of it. There was some settlement and such, and there's no admission of guilt. While I would like to point out the ProPublica article that was published before, which I thought that was a much, much better article that went into a lot of details of overtreatment of claudicants. And it was one example after another of claudicants and asymptomatic patients who just got repeated treatments till they got amputation. I mean, that one is a serious one. It's in my backyard. So, I mean, I've known exactly what's going on there. And it's a big deal. And that person, that physician ended up actually, losing their practice and license and all this stuff. Well, in this case, it's a New York, Times article, but the the governing bodies did not actually conclude that there's some, significantly, the behavior was completely out of the scope. So that being said, there's, some in there talking about more than 1,000 of atherectomy cases by each operator, which, that's pretty high. And in the papers that were published out of Hopkins, which again, I applaud the authors there for some of that work, it just talks about the top the 3% who do the majority of the atherectomy, who get the reimbursement the most of anybody else. I mean, it is an issue. There are some who just bill way more atherectomy. They get 90% of the atherectomy reimbursement is in this small tier of people. So it tells you that they're clearly overusing it. So to Frank's point, who's going to stop them? Who's going to do it? I mean, CMS may have to come in eventually, but I don't know who's going to do it, how the society is going to do it. I'm not sure what the answer there.
Are either of you involved in OEIS, Outpatient Endovascular Interventional Society?
I know them very well, and I spoke to them a lot recently.
Yeah. They do have a registry for OBL operators just to try and show quality outcomes that are comparable. But you're right. I think, like a multi-society consensus about this or some way to evaluate this just so the government isn't the one stepping in to do it would be really helpful. Let's actually shift over to talk a little bit about the industry discussions in this article. So a large part of the article was focused on payments in the OBL. So for those who don't know, a lot of times like Philips or another device company will offer financing for their products when they're used in an OBL. Basically, a lot of the industry will offer some incentives to operators to use their products.
Yeah, we have those. We have requests for proposals all the time where if we use 80% of their product, let's say it's a balloon,
right? Then
they get a discounted price. So the 20% is in some niche thing. I don't know what that term is, but we use it in a large system to decrease the costs.
Yeah. I've never really thought about it as an ethical issue, but is that an ethical issue to physicians that they feel incentivized to use a certain type of product to meet a mark?
I think the savings issue is, we use the same way. We have, these contracting that happen with a lot of, companies, and especially when it's a commodity product, that there's balloons, that there's several of them, you can use any of them, and there's a lot of contracting, and they try to kind of find the best price, and we're asked to use a certain one because we get a rebate on it if you use a certain number, and it's basically a contracting. The money goes to the hospital, right? The savings go to the hospital.
Sure.
While in OBL, it goes to the facility, which is owned by the physician who's operating. Well, it's not their fault. This is the setup. The current setup is the payments, all the work that is done is going for us is going to the hospital. The technical fees we're getting a tiny piece of the slice. While in the OBL, they control that, and all of it goes to them. So if they negotiate and they get good rates on it, they're at fault. While if the hospital negotiates and the hospital budget, balloons, and they're getting all this stuff, then that's fine. So that's something that is just, why is it? But that's the current, structure. Now, should we relook at the structure? I don't know, but they are playing within the structure that is there is. The reimbursement is, and some people could argue that the OBLs are not well regulated. Now, it's a different argument. You can look into it and say, but that's the setup. That's what CMS decided. This is how they're going to pay for it. So people are going to play within the rules of what CMS set. And as long as you're playing within the rules and you're trying to do what's best for your facility and get the best pricing like the hospital does, then you're not at fault. Now, if you're misusing any equipment and you're overusing it over a certain threshold just to get money, that's an issue. Who's going to set up the threshold? Who's going to judge that you're overusing it? That's the issue. So, we know that some do it. We know that there's 3% who do 90% of this stuff. We know that. But but the overwhelming majority, if they end up cooperating with industry, save money for their facility, which eventually comes back to them, I'm not so sure that there's a dilemma. I don't know, Frank, what do you think?
Yeah, I mean, if you're a business person and you look at this, you got three ways to finance your OBL as you build it up, right? So you can get private equity or VC money. They have a tendency to take a lot of the money. You could get it from a bank where the interest rates are high, or you could partner with a large industry corporation who's selling you the equipment. I'm not terribly against, again, I don't have an OBL, but if I had one, I wouldn't have a problem partnering, I don't think, with a device manufacturing company that has provided me the imaging. I mean, we'll get right to it. It's basically Philips, right? So they have imaging, and then they have some devices. And they have devices that I think, for the most part, work pretty well. They've got a couple of atherectomy devices. They've got very good imaging. They got some DCB. And if that's what all the OBLs do, they basically get a contract that gives them the lowest amount of prices so that they can maximize their profits. That's called being a good business person. What you have to do, though, is sort of separate out and what's the appropriateness of the care. So I don't have an issue with that. The other issue that we don't really know is, one thing for those of us in a system, we may contract out for a commodity item like a balloon. We all know that there's really no difference in balloons, and there's not a whole lot of difference in prices. And the savings all go to the system, and again, maybe something to a physician, sort of on the back end, not in any nefarious way, but we don't really know what the differences are in outcomes with regards to atherectomy. We've got a multitude of devices. We've got, different mechanisms of action, and a lot of these are priced at a lower rate so that they get used more in an OBL. And it's going to be very difficult for anybody to comment on what's the appropriateness of using a atherectomy device that's, let's say, $1,000 or $1,500 cheaper, but the reimbursement is the same, but are the outcomes equivalent for the patient? And I do think that these societies, SVS, SIR, ACC, all need to probably come together and say, maybe we do need to do some sort of randomized trial with regards to different atherectomy devices so that we know which one is actually worthwhile. That's what the cardiologists do on the heart side, and they do it very, very well. They run large trials where on the peripheral side, we just don't have a whole lot of data to say what is appropriate and what's not appropriate. We've got new devices coming left and right. I will say that it is a little bit like the wild, wild west out there on the peripheral side, in that you can pretty much do whatever you want based on economics to say, this is what I do and this is what I think are great outcomes. But we don't know that for sure from a true data side.
I mean, we live in a world of a fee-for-service, and this is the way it is. So, I mean, if a patient doesn't do well and come back to you, you treat them again and you just get more money, and it's not value-based. So this is the system that is created and incentivizes, and people are working within the framework. Some of them are pushing it quite a bit. But definitely there's no question the most use of atherectomy is in the OBL because the reimbursement is favorable. And if you ask somebody, and I've known people who did not work in the OBL, who did not use it much. When they used the OBL, they used it a lot. They went back to the hospital, didn't use it much. I mean, it's just, there's no question that it will cloud your judgment. The fact that you're going to get the full payment for it, and it's like there's not much harm in it. The issue becomes appropriateness of use, establishing a complication rate. That would be what was needed, and I think I agree with Frank's. Doing this will be great. I don't know if it's ever going to happen. The companies have to all come together, but they don't have any incentive to actually do this. So it is going to be. It's always going to be an issue, and I think the pathway that these were approved for is not great. To be honest with you, they just get on the market very easily with a very low entry, basically bar. So it is an issue, and there's no question there's an overuse. The other issue that I have with some of this equipment and industry relations in OBL is we know now the paclitaxel issue is behind us. I hope people believe that. Unless you've been under a rock, that the paclitaxel doesn't cause mortality anymore. Please believe that. So if that's the case, it's the best treatment for patients. And if you're not going to use it in the OBL because it's too expensive and you don't get reimbursement for it, which is true, and you're going to withhold it from the patient because it's too expensive for you, I have a problem with that. In a DCB, for example, in a fistula, and it's been shown to be superior to regular angioplasty. If you want to withhold it from the patient because it's too expensive, or anything else you want to withhold it for economic reason because it's too expensive from the OBL, well, you're making decisions, financial decisions the other way by overusing atherectomy because it works well for you. So this is one of my big ethical dilemmas, and I had a lot of discussions with my colleagues and my former trainees who work in OBL. And I just asked this truly is, I keep probing it, and I know there is an issue here. And there's a decision that is based on economics of what device to use for the patient. And that is a problem. While it's many times in the hospital, it's less of an issue. You would truly try to use what is best because it just eventually gets lost in the shuffle. So it's not an attack if anybody from the OBL is going to come after me after saying this, but I would, challenge anybody to tell me that it's never factored in their decision. And that is part of the major issue with the current reimbursement structure of OBLs.
Sure. No, all really good points. One big concern from the New York Times article is that insurance companies can use the article as a reference to start denying prior auth and payments for services that are, especially for people who are treating PAD in the OBL. Apparently, this is already happening. Dr. Krishnamanava sent us an example of a patient that happened to him very recently after the article. Anybody care to comment on that?
Well, it sort of makes sense a little bit because they're sort of probably a little bit curious as to the appropriateness of care of some of these patients. The problem is you just don't know which patients actually will need another intervention in a relatively quick fashion. Like I would wish I could say that I do an intervention. I've never had to do another intervention on that same leg within 6 months, but we all know that would be false, for a variety of reasons. Maybe they need to be on anticoagulation, they've been on it, and they can't afford their anticoagulation, thrombose, whatever it is. And that is going to be a problem. I think this comes down to how we pay for these patients. And, it's certainly going in that fashion, on the orthopedic side, in which you have bundled care for the care of a leg or a vessel, over a month, over a 6-month period of time, over a year period of time. But I think that's going to come, and I think it should probably come a little bit sooner. And I think that would then force a lot of the individuals within the hospitals and in OBLs to do the right thing to try to get the longest, patency that we can for those vessels. But I agree, this fee for service is going to be an issue because it sort of pushes you to do the intervention maybe a little bit quicker. I mean, those would be my thoughts on that.
It's unfortunate that somebody's going to have to come and regulate. And the worst to come and regulate this whole thing is insurance companies. So that's the worst thing that could come out of it. But definitely moving into something that is value based, that is, treatment of you get reimbursed this X amount of money for a segment or a leg, or an artery over 6 months, and if you have to come back again, it's on you, for not appropriately doing the right thing. But it's going to happen. So you may win some, you lose some. So I think something along these lines would be great. And it's going to be tied to payments. Of course, CMS may do it on their own, but we could help them, get to that level. But it's a far-fetching goal, of course. But that would have been a more ideal scenario. That being said, I could easily see the issues of if Dr. X treats the patient, that doesn't have a good outcome, then they send him to Dr. Y. And now
for the free case, yeah.
Now you inherited a patient that you want to treat, but you're not going to get paid for because they already reached their maximum. You're treating them within a month. So there's all these issues that are, fraught with that is not, because it's a different pay. So there's all these things that need to be resolved and such. But there's no question that it needs an overhaul. The way we pay for these services need to be overhauled. Just the fact that you just get paid this much more in an OBL than in a hospital is an issue, and the fact that repeated interventions are to your favor not against you is a major issue. And, it has to change somehow, somewhere.
What would you do if you were the physician discussed in this article?
Yeah, I mean, probably the way I would answer is if I was, jihad, what would I do? I'd have to have some introspect and decide whether or not I was actually doing the right thing. That's what I don't know. I suspect he saved a lot of limbs. I suspect that he's trained a lot of people to do some pretty advanced endovascular procedures. I've seen him operate, in live cases. I think he's got a very good skill set. The appropriateness, I cannot comment on, but I think if you deep down feel like you're doing the right thing and your appropriateness is good, and your first case is that they present in the New York Times as a CLI patient that loses her leg 18 months later. I mean, that's happened to almost all of us, I would imagine. So he's got to deal with that. I think time will heal, and I think if he's doing the wrong thing, then I think that societies, and specifically the ACC, which is his society, should probably go in there and do an evaluation of what's going on. Although it looks like that was already done. He had a small fine, required, I think, a little bit of education. The fine wasn't, frankly, I've never been fined, so I don't want any fine, but it wasn't the worst fine I've ever seen compared to the ProPublica, who is no longer a practicing physician. So I've got to think that the board has an understanding of what's going on a little bit better than what we're doing, and I would just probably ride that out. It appears that there's some, local politics going on in the area that I think I can sort of see from the article, but I don't really comment on it. I don't have any personal relationship with any of the individuals there, but that's sort of how I would go on it. You could also get to to a legal response about it. If you really want to fight it hard and you think that there's some injustice to the article, then you would go to that next step, I would imagine.
I mean, I think we're all gonna have complications, and I think if your complications are mischaracterized, I think you just need to show your data, and I think these need to be litigated in the proper way, not on media pages where maybe journalists who don't quite understand the nuances of it. There's no question there's some local politics that played into it. I totally agree. Clearly, you can see that. So I would say that you have to come, with your data and see what your outcomes are and be very clear about it and have to defend your practice. I mean, I think that's what I would do, show. I mean, we've all had issues with complications, and you get investigated by your hospital to start with, and QA committee is like, is this procedure too risky? You guys have 2 complications the last 6 months, and then you're just like, okay, we've been doing this for, 10 years. We just had 2 bad outcomes the last 6 months. And, these are the steps we're going to do to make sure this doesn't happen again. I mean, this is how these things are addressed. And if it's too much, then it goes to the medical board, and then they look into it, and there's misuse, then it gets. So that's the way it should be done. And I think that's how, I think I would address it as like what was done by the authorities. And I don't think the societies, unfortunately, have a whole lot of say, the professional societies, whether it's SCI or ACC for the cardiologists or SIR, or SBS, to try to govern the physicians. The physician that was mentioned in the ProPublica article, or the vascular surgeon, was not a member of SBS. So, you don't have a whole lot of ability to govern that from a society perspective. Unfortunately, it's the state medical boards and who are going to govern it, because if you're not credentialed at a hospital, so the hospital can do anything. If you have an OBL, they're not really that regulated. And I agree that we need to have better regulation over the OBLs, and it's literally just left to the state medical boards now as the only group that can do much about it. And I agree with the calls from a lot of people that we need to have better regulation. And OEIS is a voluntary organization. They're excellent people who are trying to do the right thing, and the registry is voluntary. So the ones who don't want to participate, they're not going to participate, and they don't care. So
that's a good point. Good point. Yeah. Any other comments that we haven't really touched on about the article? Anything that made you really mad or really upset?
I want to talk about there are more. They're going to be coming more responses coming from other societies who decided to write it out, and so there's going to be multi-specialty response. Is going to be probably by the time you guys listen to this, probably is going to be out by a lot of societies. Are coming together to try to kind of write a response in a better way that is kind of talks in the whole, try to hit the main points of CLTI, patient education, education of the public, different presentations, appropriateness of use, and the ability of all specialties to care for the patient as long as they practice appropriately. These are like the framework, what is going to be discussed. So I think that should be a positive thing. There's also a lot of groups who talk about healthcare disparities are going to come out with notes about this and maybe comments about it and try to kind of maybe use it, try to kind of, get some, lemonade out of lemon. Basically, if there's some, there's some publicity about it, maybe try to push hard to talk about the disparities that are going on. And there's a lot of work that's done by the PAD collaborative that's led under the AHA to try to kind of highlight certain things, including heat map for amputations by congressional districts. And there's try to kind of push it in Congress to show them the amputation rates. And there's bills coming through, sponsored by members of Congress who's going to look into it. Try to kind of, hopefully at some point we can get, payments for, screening for ABIs and such. And so, there are a lot of work that can be done. And I think maybe this could be a chance to highlight some of these efforts and talk about them more and maybe get some more groups together to work together. And I hope that everybody tries to find the positives on it, try not to kind of miss an opportunity to reach across and bring down the silos to kind of better the patients.
Very well spoken. Yeah. Dr. Arko, any other last comments?
Yeah, I thought his last comment was excellent as well. The only thing I would say with regards to the article is I did find it to be, dividing among specialties and sort of towards that end. There was some, all specialties maybe have some training in it. This has to go well above and beyond, what vascular surgery has to offer, which is, one component of the care of these patients, which is a bypass in a certain number of the patients. And we just don't have in my personal opinion, we just don't have the manpower for vascular surgeons to take care of all these patients. And then to try to divide us like that, I just think was wrong. And I think we can do a better job. And, if you take a look at where the majority of the vascular surgeons are, they're all in large cities. I've worked in the middle of the country, albeit in a big city, Dallas, Texas, but I got a lot of referrals from areas that were 2, 3, 4 hours away that had no vascular surgeons, and everything was being cared for by general surgeons, cardiac surgeons, radiologists, and cardiologists, for which they're not the cardiac surgeons, but the other three groups, there are a lot more than there are vascular surgeons. And to be honest with you, they do a pretty good job for what they can do in those small cities. And until we can get a larger group of vascular surgeons to say, I want to go out and work in a town of 20,000 with the nearest referring city 3 hours away, I think we have to be more inclusive for the management of peripheral arterial disease and CLTI and really work as a group. There's just too many of these patients to manage, and we've got to do a better job of recognizing it early, getting them in the hands of those who can treat it, whether you're a cardiologist, a radiologist, or a vascular surgeon. I see very good care from each one of those groups. And I think there should have been a little bit more emphasis on the fact that because there's so much disease and the OBL and the ASC can take care of these patients in a much more efficient way than a hospital, and the government is pushing it towards that. All we need is probably some regulations, some changes in the payment, and these systems actually, I think, can work very, very well for these patients in the long term.
Great. Awesome. Well, thank you both for this fantastic discussion. We are going to link to both the New York Times article and the ProPublica article, as well as the SVS and the OEIS response in the show notes for anybody who's interested. And yeah, thank you for being on the show.
Thanks for having us.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
Jacob Fleming,
and Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.